So hey, I'm Dr. Nancy Reed. I'm the regional lead for radiation oncology, and thanks so much for letting me come. I actually emailed them and begged them to let me come and talk at this session. So they gave me a few minutes. I'll try to be brief. I could probably stand up here for an hour pretty happily, so I'm trying to keep it to my 5 minutes. The reason I wanted to come is Cancer Care Ontario looks at a wide variety of things in oncology to make sure that we're providing good cancer care provincially. And one of the things that they've started looking at recently is something called radiation utilization. And what that is what the radiation utilization is it looks at the proportion of patients who've been diagnosed with cancer who are actually getting radiation. And it's really clear that province-wide, it's not just in our LHIN, but province-wide there's a big gap between the number of people who really should be getting radiation and the number who are. So we're trying to change that, and when you look at this information, the biggest gap is actually in older patients over the age of 70. So we're all trying across the province desperately to figure out a way to get more people through our door, to get them in and to have them have the opportunity to have radiation. So what I wanted to do is just go through a few things that are new, the high points of where radiation is useful. And if you take nothing else away from my 5-minute talk, is that if you have a cancer patient and radiation even crosses your mind, please send them to us. We are really happy to see them. And even if it turns out we don't recommend radiation, we'd really rather do that, see them and have the opportunity to at least offer them what might be new. So let's go through this quick because I have too many slides. I don't have any financial interests at all that are conflicting. So this is the other big slide that if you walk away, again, don't listen to the rest of my techie geek info that I'm going to give you. These 4 things are where radiation can be helpful in cancer patients, so particularly in palliative treatment. Bone mets, obviously, obstruction problems, esophageal, lung, and biliary, lung, liver metastases, and brain metastases. We can be really helpful in all of these areas. So I just wanted to give you just a brief glimpse and what are the sort of things we can do and what is new. First is bone mets, and this is probably the biggest volume. We all have lots of patients out there that have bone metastases from their cancer. And the thing that is become increasingly clear over the years is that a single radiation treatment can be just as effective as multiple treatments. There's now randomized data that has compared either 5 or 10 treatments to one treatment, and it is very clear that the single treatment is, if anything, better tolerated and gives as good a result as multiple treatments. So that's really useful for your older patients, particularly where you're concerned, travel is an issue, they don't want to come in repeatedly. That single fraction can be very, very helpful. And in terms of what you can expect in terms of control, about 80% of patients will have significant improvement in their pain. You can get a complete response in pain at about 30, and as I said, if you look at these numbers, they're exactly equal whether you've got multiple fractions or a single. And the great thing about the single treatment too is, let's say it doesn't work perfectly the first time, it's really easy to do it again. They'll tolerate it well, and you can get away with it nicely. So the one thing I really want to emphasize with this single treatment option is we have a program at the London Regional Cancer Program called our Rapid Response Clinic. And what happens in this clinic is we see patients, they're seen in consultation, they have their radiation planning, and they have their single radiation treatment delivered that very same day. So this is a great option for people who are perhaps more elderly or live a long distance away or have issues, they're the caregiver for somebody at home. Travel is just not an option for them. So I think this is something you need to know about. Now, we can't deal with every single cancer patient in this manner. It's just not practically possible. But if you have a patient like that you think, they won't come if they think it's going to be multiple visits, but if you think, maybe I can get them to come for this one day, when you make the referral, just sort of query rapid response, and we can get them booked in that way really nicely. And it's a great option for people. And there's great evidence that this can improve the quality of their life, which is really our goal. So what about obstructive issues? So as I said, the big area is lung, esophagus, and liver. Radiation can be super helpful at relieving the symptoms of all of these issues. Usually it has to be more than one treatment, usually 5 to 10 at the most, and you can make a big difference to the quality of life. The other one is a brachytherapy, brachytherapy is radiation therapy delivered internally. So it's putting a radioactive seed in, and again, that's usually 1 or 2 treatments, brief, well tolerated, often a good option, particularly for esophageal patients who are obstructing and having difficulty eating, occasionally lung patients as well. I actually have this picture, which is kind of neat. It's, I don't know if there's a pointer on this thing. Is there a pointer on this? Anyway, you can see at the left, there's a mass just at the hilum of the liver, and it was causing significant obstruction. This patient was very jaundiced. We did just a couple of fractions of radiation therapy, and you can see on the right that it's completely resolved, it's opened up, and they had we didn't cure this patient, obviously, but their quality of life was vastly improved, and they had several more months of good quality of life. So, kind of on this note, the thing that is allowing us to do this now that we couldn't, a decade ago, you couldn't have sent me that patient, I couldn't have done anything useful for them, but now there's a lot of new radiation techniques that are allowing me to get higher doses of radiation into these areas without causing a lot of toxicity. That's always been the problem, is to do radiation, it was just too toxic, the liver wouldn't tolerate it, the lung wouldn't tolerate it, but now we have all of these fancy new things that are allowing us to get higher doses in. The other thing that I wanted to mention and make people aware of is these techniques are also allowing us to treat early lung cancers in patients who would otherwise not be fit for surgery, those older patients with poor lung function. Often using these fancy techniques, we can get high doses in and treat them beautifully with actually controls that are, if anything, a little bit better than surgical intervention. So it's really promising. So I've put them all there, IMRT, IGRT gating. You guys don't care what those really are, but what they do is just allow us to sculpt radiation doses. So IMRT, it varies the intensity of radiation as we deliver it. It's very precise, and we can actually sculpt our dose around critical structures. We can avoid treating as much of the liver. We can avoid treating large volumes of lung. And obviously it gets high doses, lower doses to critical structures. That's good all around. Better cancer control, less toxicity. This is just a picture of our machine. This is the other thing that allows us to do this is something called image-guided radiation. And what that basically means is when our patients are getting treatment, they actually have a CAT scan done while they're getting that treatment delivered. And that allows us to make sure we're actually doing what we think we're doing. So it's a very neat advance. We used to just put tattoos on, and then we kind of had to hope that what we were delivering was what we thought we were delivering, but now we can confirm it on a daily basis. Huge advance, and it just lets us do a lot more that we couldn't do before. And gating is the other one that really helps us. Gating is basically that the radiation machine turns off and on with the patient's respiration, so it's really useful for delivering radiation to things like lung tumors. You can see here, lung tumors move significantly, so we can make it a lot more focused. So I have one more thing I'm going to mention, and that is oligometastatic disease, because this is something that we didn't used to treat, and it's something that we are looking at more, and that is when a patient has a really limited volume of metastatic disease. It's usually patients whose disease is otherwise controlled, so they're not even necessarily symptomatic. We used to often not do anything, or maybe just some chemotherapy, but now there is a role for radiation. And there's some evidence that people can have potentially improved outcomes. So we actually have a randomized trial, and this is started by one of our really bright young radiation oncologists, and this is a worldwide trial now that is trying to look at, does that really help people? Are we doing better by delivering higher doses of radiation to smaller areas in these patients? And it's easy. It's just usually somewhere between 2 and 5 radiation treatments. It's not a big time commitment or toxic time commitment for patients. So it's something, if you have somebody who maybe you think, oh, well, they've got a couple of bone mets, but they're not really symptomatic, I think, we don't need to do anything. It might be worth referring those patients as well to us, because there might be something useful that we can do. So I'll leave it there. Okay. Thank you.